Get away.
Okay, so yeah, thanks, Jason, and thanks to Brina for inviting me to do this, and welcome everyone who has taken time away from your busy schedule and maybe a possibility of a lunch break to be with us today. Um, Pardon my barking dog. She likes to find the most inconvenient times to decide she needs to bark at nothing. So um, I had posted a message in the chat. I'm not sure if everyone can see it. Maybe Jason, if you're able to share that with folks who maybe can't see it, if anyone tells you they can't. I do have the slides from today's session and a resource list in a Dropbox folder for y'all. So um, as Jason said, I'm Erin Beckwell. I'm a social worker. I currently work at the Faculty of Social Work at the University of Regina, and also do some quite a bit of teaching about trauma and related topics, and do a fair bit of research as well on the topic of pain. And so the two mash up quite nicely today. So I'm going to get to it, and there's a lot to get through in the time we have. So I just want to start with a brief territorial acknowledgement. I'm coming to you from Saskatoon in Treaty 6 territory and homeland of the Métis. And I just think anytime I talk about trauma and adding the layer of pain into this, I think there's so much we can learn and sort of better understand if we sort of immerse ourselves or integrate Indigenous teachings and ideas into the way we understand health and relationships and healthcare. I also know, though, that Indigenous folks experience additional stigma and structural barriers when attempting to get both trauma and pain addressed. And I think often the intersection in Indigenous communities is very complex. And so I'll maybe allude to that if we have time today. So I just want to dive right in then and talk about trauma. I just wanted to make sure everybody had a sense of what I was talking about and how I was talking about it. And so trauma is something that is still quite misunderstood in the world, including a lot of times among healthcare providers and healthcare systems. And so trauma is a response to an event, a series of events, a set of circumstances, or the possibility historical and intergenerational trauma as a broader context surrounding events, series of events, and sets of circumstances. And so that experience in and of itself isn't enough to sort of cause trauma. Um, the nervous system needs to interpret what's happening, needs to sort of have a felt sense that there's a risk or actual threat of physical harm, emotional harm, or life threat to life and limb. And so, an interesting thing that happens with pain is that sort of response mechanism becomes hypersensitive often, and that can be a critical link to understand. And so then when we look at trauma and how we understand trauma, we're often looking at the adverse effects of trauma. And so it's those often long-term, possibly lifelong effects on all aspects of functioning. And one of the challenges is that those symptoms of trauma often can look like a lot of other things. And so, from a healthcare perspective, I'm not sure what my dog's issue is. Sorry if you're hearing that. From a healthcare perspective, I think that one of the challenges is how do we discern and separate, pull apart what's a legitimate physically caused symptom, pathology, illness, injury, etc. What is something else? And generally, my guidance on that is if we've ruled out pathology, injury, illness of various kinds, and we still see symptoms persisting, um, I think sometimes there's historically at least been a tendency to view that as psychosomatic. And in many ways, it actually is. But the way we have talked about psychosomatic symptoms, I think, has been very stigmatized, very sometimes judgmental, dismissive, even. And so when we have these remaining symptoms after we've ruled out other things, I think it's important to ask ourselves, even if it's just a reflective question, could this be trauma? Could this be something we're seeing that's a nervous system that's dysregulated, and we're seeing these symptoms as a result of that? And we'll talk more about that in a moment. So trauma really comes from a sense of overwhelm, often a chronic sense of overwhelm in many people's lives. It might be one event, but often there's multiple series of events or sets of circumstances that are resulting in people's nervous system interpreting what's happening around them as too much, too fast, too soon, and sometimes not enough. And so, too much could mean I have too much pain to cope with right now. And so pain in and of itself can be a source of trauma. And I'm going to get back to that in a minute. Um, but what's happening might often feels out of control. And, the nervous system just can't quite catch up to what's happening. So it's coming at us too much volume too quickly. We can't adapt. We can't, sort of get a sense of what's happening to us. There's often a sense of lack of control in these situations. Maybe it's too soon after a previous event that's been threatening, harmful, or perceived as those things. And it could also be too soon, as in too early in life. Young people have limited capacity
Anyway, just
to
go now.
respond to
What if
threat
they change their
in
mind 2 days before
in a way
Halloween and
that
they
makes
want to be
sense of
something
what's happening.
else? Yes, there is a high probability that that
Just
will
getting some
happen.
background noise there.
Actually, it's almost
Thank you. And so the not enough piece, I think, is an interesting one that sometimes I think it doesn't get the attention that the others might. So it might be a lack of or absence of love, safety, trust, belonging, connection. And so one of the things that I often talk about, and I will try not to go too far into this in this session because we have so little time together, but I have lived my entire life with pain and trauma. And that's partly why I have a passion for this topic. Um, One of the things that happened for me, though, is very early in my life, there was a lot of questions about what was happening to my physical body. I was having pain as a very young child, even at a pre-verbal age. And of course, that's very difficult to discern what's causing pain. And it can be quite challenging, especially when tests are done and procedures are done and there's no conclusive result. And so I grew up and now understand I had a profoundly disrupted sense of safety. Um, I was subject to all sorts of tests. It was the 70s, and some of my painful tests were done without pain management. I was also not offered pain management. That wasn't something that was offered to, uh, people who had this pain that wasn't able to be kind of diagnosed, recognized, validated in some way. And so over my adult life, I've come to understand the impact of that. That, at the age of 2 or 3, I was experiencing things that were unsafe. I also, because I'm a bit of a, I don't know, medical weirdo, I'm also, I was photographed for medical textbooks and presentations. And I didn't consent to that, right? So things were being done to my body that I didn't consent to. Of course, the intent wasn't to harm me, but the impact nonetheless was that I developed very significant trauma symptoms that then were also not understood. And that is, I don't think that unusual. Maybe having that experience all the way back to birth is perhaps unusual. I would say not always, but being able to find language to make sense of what has happened in my life has been a critical piece of healing my pain, which is something I'm going to talk about in a few minutes. So one thing I just want to mention before I move on is that, of course, when we look at who is most likely, I mean, anyone can experience trauma, right? Trauma doesn't discriminate, and anyone can experience, especially early life experiences, but at any point in life, absence of love, safety, belonging, trust, etc. But what we know when we look at this and we think on a population health level, who has the highest rates of this, who is likely to have the highest rates of this type of experience. And we can look at people who have, intergenerational trauma and community level trauma. So Indigenous folks often, this is part of their experience. Uh, Sometimes newcomers, people, especially people who've gone come to Canada as refugees, people who've experienced environmental disaster. There's a variety of things that can happen that both overwhelm our system and create this kind of gap for our nervous system. And but you can see how, as an equity issue, trauma tends to be more prevalent in groups of people who already face very significant health inequities and gaps in terms of being able to meet their survival needs. So trauma isn't really about what happened, and healing from trauma is often not about going back to what happened. Um, and that's one of the big myths of trauma, and I think it keeps a lot of people from addressing what they may have a sense is a trauma that they need to deal with. There's a real fear, for good reason, of going back to things that have happened in the past. Sometimes we can't remember, or it's a complex combination of things that have happened that it makes it difficult to discern when did it start, what triggered it. It's and trauma can certainly become more complex over the course of someone's life, right? And that's been my experience. I now have possibly CPTSD, which I know is not an official diagnosis yet. But this notion of complexity of trauma as additional things happen in someone's life. And one of those things can be the addition or change of the nature of pain in someone's life. And so the same experience could be traumatizing for one person and not for the other. And that is really, really critical to understand, is that it's not about what happened. It's about how our nervous system, gauges threat and then responds to what happened. And everyone's nervous system is unique. One thing that's important to know is one of the conditions that can lead to a nervous system interpreting threat in an environment and responding in a way that presents ongoing challenges for someone, ongoing health issues or symptoms, is that if you have pre-existing trauma, whether it's been named or understood or not, it can have your nervous system be more sensitive. So you're more likely to then, sort of experience subsequent trauma. And so that's, I think, another challenging piece of this story for a lot of the folks that we see. And so you can imagine when we talk about the connections between pain and trauma, there's a reason I made the title of my presentation, the pain of trauma and the trauma of pain, because in a lot of ways, it's a bit of a what came first, the chicken or the egg situation for many people. So trauma can be a cause of pain. We can have an accident, an injury, an illness, or other overwhelming experience for that matter, that results in pain. And that pain may be a very real, diagnosable, visible, or accessible physical pain. Persistent pain can be a source of trauma. And I think that's a piece that gets missed. And I know certainly in my journey with chronic pain, it's not something that has come up. And I've seen dozens and dozens and dozens of healthcare providers over the years continue to. And it's been interesting realizing that I continue to have pain. We've sort of run all the medical intervention options on that. And there is generally then a sense that, oh, there's nothing else we can do. And it has taken my own sort of desire and yearning and just need to know what else could make this better. That's led me into this world of understanding these intersections between pain and trauma and recognizing there actually is something we can do. And I think there are still really big challenges in accessing those somethings, and I'm going to talk about them in a minute. But I think it's important to recognize that having people be in persistent pain can create a new trauma response on top of existing or as a brand new experience this person's never had before. Past trauma can be stirred up by subsequent pain. There can be triggers created by the way pain manifests in our body, where it's centered, how it feels, that may remind us of past trauma. And so it can stir up things from the past. It doesn't have to be that the pain is the same. It may be the pain leaves us feeling out of control. And when else have I felt out of control? And then those symptoms, trauma responses start to stir up because I'm feeling the same as I did back then when I was harmed by this incident, or I was under threat, so I should react the same way this. And of course, this isn't a conscious thought process. This is a nervous system that's basically overriding our conscious thought process and telling us, no, you're under threat. Get ready, brace yourself, and often then that bracing behavior can actually intensify pain symptoms. Early life trauma, which could be prenatal trauma, there's some evidence, that what happens in utero can impact someone when they're earthside. Perinatal attachment or developmental trauma. So, anything that disrupts attachment, which can include medical issues where an infant is hospitalized, although I think we've made some pretty good strides in trying to keep um, parents with their kids, especially when they're ill, and make sure those opportunities are available. But there's still, many things that can separate a parent and child, or caregiver and child. And of course, things like apprehension into child protective services is a significant disruptor of attachment and developmental trauma. But having a parent who dies, having a parent who is struggling with their own pain, which is interestingly part of my story, is I have a mom with chronic pain, and part of her ability to care for me when I was young, especially given that I had complex medical needs, was impacted by the pain she experienced on a daily basis. And so she was not as available to me. She also, it was the 70s, and the cry it out philosophy was a big deal. So, my mom didn't have a ton of capacity to parent a new baby who was not well. And, I know from family accounts that resulted in me being left to experience my own pain, whether that was physical or emotional, without intervention from a caregiver. And so trauma can sort of be, the groundwork can be laid for that trauma early in life, which then if we have something happen that results in, persistent pain that can't be relieved easily, that may then impact how we experience that pain. And it can, trauma can impact sometimes pain tolerance, or just the way pain feels to us, our felt experience of pain. And so the other thing to remember is that the onset or progress of chronic pain or illness can feel traumatic. And so that there's a name for that, sensitization trauma. So it's that central sensitization response that feels traumatizing because we do not have control over our own body and what is happening in our body. And that sense of not having control often then has very profound effects on other aspects of people's health and can intensify felt experience of pain at the same time. So it makes pain worse often for people, which then it creates this cycle. Pain is worse, feel out of control, often have some fixation on pain, anxiety about pain, catastrophizing pain, and then that sort of increases your pain and repeat, and all of that wrapped up together can result in experience of trauma as well. And so one of the things that happens with trauma, and we look at sort of this from a polyvagal theory sort of lens. There's this language about patterns of connection, which humans are wired for connection. We need other people to survive in the world. And so connection is healing, and connection is essential to well-being. And so when people experience trauma, often they are sort of rewired in a sense to prioritize protection over connection. And so there's this persistent sense of threat. And so the world starts to feel threatening, relationships might feel threatening. Places where you typically would see a hope of care, like going to a physician, going to another healthcare provider, might feel like a threat rather than a place to go and get better. It's often a place where people have had experiences of both not being in control of their body, being told their body doesn't make sense, or we just don't know, which then leaves people in these patterns of protection. And so I won't be able to go through all of these, but essentially the polyvagal theory has, sort of is the basis for, or aligns with the notion of fight, flight, freeze. There's also been some additional work on what trauma response can look like. And so patterns of protection can be fight response. And I think when it comes to pain, we see people who might take on a like, I'm angry at my body. I'm going to take over. I'm going to take back my power, which might sound good, but it's often coming from this place of fight that I'm not safe in my own body. Therefore, I need to fight my body, which typically doesn't help it get better. Um, and so, language around pain may be very important here. Looking at, talking about needing to fight your pain can actually sort of get people a little stuck here if they feel that is what's expected of them or that's what's endorsed. This sense, well, you got to be willing to fight every day. You have to be willing to get up and, sort of go another round. And so we need to be really cautious about that. People may struggle with emotional regulation of a variety of sorts in all of these categories. And in a fight response, it's often anger, defensiveness, suspicion, rage, impulsivity, going big. So this was when you might see, a patient or someone um, sort of go big on you, right? Like take up space, yell, um, just big emotions. A flight response is about keeping separation, keeping distance. And so it's sort of the traditional, I'll run away from the threat. And of course, when the threat is sensed as your own body, it's very difficult to run away from yourself. And so people often will end up retreating into their head. Certainly, that has been a very strong theme in my own experience is feeling like I exist from the neck up only. And I can then separate myself from the threat, which is the pain I feel in pretty much everything below my neck. Although these days it's crept into my head as well, which is really lovely. But folks might also keep themselves away from healthcare providers, healthcare settings like hospitals in particular might be sensed as threat. So threat can come from outside and inside. And so flight then becomes complex and often results in people disconnecting and just sort of, detaching or going all in. And for me, most of my adult life, I've struggled with workaholism, which I know is terrible for my pain and my overall well-being. And yet it is my avoidance tactic. And this is where we see a lot of the coping strategies that people try to manage trauma and pain is things like numbing and avoidance, substance use, which I know, is very relevant to the folks involved in this group, is this notion that people will find what they can to sort of numb out from the threat and not have to feel this sense of danger all the time. And so people can do that through a variety of things, but that's often when opioids are prescribed and trauma is also a part of the story. Opioids can feel like a really nice, warm blanket that helps me numb out from this constant sense of threat. And I struggled for many years with um, what now might be labeled opioid use disorder. At the time, it wasn't discussed. Um, and it was, prior to the sort of more recent advent of concern and thoughtfulness around use of opioids to manage chronic pain. But that was the solution that was given to me. And so it became a really useful coping strategy. And of course, when that wasn't working well enough anymore, tolerance was building, I was going back for more and more, and then it was a problem. And I was very, very hesitant to let go of something that had helped me survive these big sensations and the very real pain I was experiencing. And so I think this is where we need to be really mindful if we're talking about tapering off, if we're talking about changing treatment plans, that we realize this isn't just addiction talking. This is coping strategy that has served me talking. And that, people will go to great lengths to keep and protect a strategy, a behavior that helps them feel like they can survive. And substance use is incredibly powerful and effective in that survival realm. It often isn't great for chronic pain. We know that. But when people are introduced to that, it can feel like the answer temporarily. And so people keep coming back to it over and over again. It can be incredibly difficult to let go of unless we're able to address some of the underlying issues, which, of course, in healthcare today is very difficult because we do not necessarily have the resources and supports available to do that easily. There's incredible wait lists, and sometimes the very services that are needed just aren't available at all. And so then we have a freeze response. It's a shut down, stop and stay. So people may be minimally engaged in care if they're in a freeze response. They may appear very depressed, very isolated, which of course we know are side effects of just living in pain. So these things start to blur, right? People may become despondent and feel very hopeless. There's no point, which of course, again, is very common in persistent pain. So I would say this is one that is a bit tougher to discern. Is this trauma? Is this pain? And I would say from a social work perspective, I don't know that it matters a lot. We can certainly try to treat things like depression. And I'd say if the depression treatment isn't really showing much effect, we should again be saying, could this be something else? Could this be trauma? And an antidepressant isn't going to fix a trauma response. So what else can we do? And often that's a big question that we don't often have great answers for, sadly. And then there's a fawn response, which is essentially, called people pleasing most of the time. But it is this notion that I will care for others, I will befriend others, I will become incredibly likable, or very almost fading into the background where I'm just not noticeable. Um, and this was an interesting piece for me, even in my own journey. I had a specialist, my rheumatologist said to me, Erin, you don't have to be my favorite patient all the time. And I learned that I realized that I had learned over the course of my life that that helped me to feel in control a little bit of, but it also meant I might feel safer if I'm the charming, funny, compliant patient. Then I'm going to get better care. I'm going to be safer in the hands of my healthcare providers. And so that can also be a trauma response, and it certainly has been one that I've had to wrestle with my whole life now. Is I'm everybody's friend. I have to be, right. And caregiving to your own detriment. If you have a pain issue and you're overriding your pain all the time, you're not giving yourself care, you're caring for others and almost sacrificing yourself, knowing you're going to cause greater amounts of pain, etc. So these folks often try to shrink away so they're not noticeable, or if they're taking up space, it's a very like pleasant, neutral, I'm a helpful, lovely person to be around. Maybe not happy, but I'm certainly not needy, disruptive, burdensome in any way. So one of the things that's interesting is that neuroplastic pain, so that persistent pain that doesn't have the cause of, pathology or injury, those sorts of things, this is nervous system pain, right? And so um, it can be the response to that perception of danger, which means pain can become a pattern of protection. So in paradoxically, taking away pain can feel like a threat. And that makes no sense, which whenever things make no sense in a logical sense, anyway, that's when I'm often like, oh, is this trauma happening? Because trauma doesn't follow logic. Trauma actually trumps logic. And so trauma responses in our nervous system say, no, we have to go on autopilot because we're under threat right now. We need to hunker down, run, fight back, right? Keep everybody happy around us so we're safe. And pain then becomes part of that attempt to manage. And so, more broadly, both pain and trauma often involve that loss of control, an altered sense of self, and hope for the future. There's a lot of grief and loss involved in both. Negative impact on interpersonal relationships, which we know often go along with both. Invisibility and distress of suffering, that pain can be, it feels very visible when you're in it. And often, though, on better days, good days even, people feel, well, you mustn't be in that much pain on your bad days because you're moving around so well. And And so that isolation, suffering, those sorts of things. And then chronic stress, and then stigma is sort of the other layer of the sandwich, that there's a stigma attached to um, pain and trauma, and those experiences, which is one of the pieces that I'm part of a team that's researching right now. And so stress and trauma is important to understand that, of course, there's a lot of factors that affect those, and that's what's in the box in the middle, is all of the stuff that impacts how we interpret what's happening around us and whether we feel it's stressful or not. And so recognizing also stress responses is important. And often stress responses can kind of mirror or mimic trauma responses a bit. And so, what happens when you're highly stressed? Well, people with persistent pain often are in persistent stress. And we know that has an impact on our physical well being, our mental health, our social, our capacity to interact socially, et cetera. And so there's a linkage here, and persistent stress can also become a source of trauma. So you can see how this is just threads that are interwoven, sometimes knotted up in great big messy knots that are really challenging to pull apart. And so to heal chronic pain and symptoms, ultimately it's about often a very titrated, and that's the language that's typically used, a gradual, slow, gentle, compassionate, curious approach that helps people learn about their nervous system, understand how the things in their environment, the things in their body, especially their feelings, emotions, are impacting the state of their nervous system, and to help people come back to a place where they feel they have some control over how they feel. That doesn't necessarily mean their pain will magically disappear or their trauma symptoms magically go away. But what it means is people are better able to adapt to, live with, understand what's happening, which often helps settle a lot of the distressing symptoms, just by giving people a sense that they understand what's happening, they have some control over it, and they're able to recognize things that they may be thinking, feeling, or doing that could be adding to their pain or adding to their stress. The other thing I want to mention really quickly, just before we have time for some questions, is that people who experience trauma very often have experienced service delivery that mirrors their experience of trauma or is the source of trauma. And so, for me, for example, some very early memories of hospital care that were not good have impacted my experience in hospital, that continues today. However, I have yet to experience much sort of care, especially around things like surgical procedures, that doesn't make it worse. And I don't believe that anyone's intent is to make it worse for me, make it harder for me. But especially given, I'm now nearly 50 years old, I've had over a dozen surgeries, a whole bunch of other things. And every time I have a surgery, I absolutely panic, and I have big emotional response, often can't settle. And I've had people say things to me like, oh, be a good girl for us and treat me like a child, which of course triggers me. But also things like, oh, I've had kids that have gone through this procedure and they've cried less than you. And none of these things are helpful. But also attempts to sort of have a better experience in surgery have often been disregarded by healthcare providers. So having conversations in advance about a procedure and my potential response to that and what could help me. I've had even my most recent surgeon said, "Why don't you leave those big things to me and you just show up?" And I was trying to tell her that I needed to know some things, have some control over something, and that having a sense of what the plan was would help me. And it was just kind of brushed off. And I think there's just a shift that needs to happen in how we interact with folks. And I know it is happening. And I know many people on this call are likely already in that process. But there's a bigger system shift that I think it needs to come. And so, um, we'll have some time for questions, comments, if you have stories of your own you want to share. But the last thing I want to say is this. The general idea around how to best sort of treat trauma tends to focus on somatic approaches to therapy. And by therapy, I mean sort of mental health style therapy, counseling. And that is incredibly difficult to access for a lot of people. It typically is not easily accessible within our publicly funded healthcare system. It may be available to folks through private practitioners. There are others who do somatically oriented therapies. So some physical therapists, massage therapists, and others who've been trained in some of that. But most of the work on trauma and managing pain happens in more that sort of counseling or therapeutic relationship of that sort. And it's certainly something that only folks with often immense privilege have access to. And I think that's an important piece to be aware of. I have included a couple links on my resource sheet that if you're working with folks who, might be able to explore some of these types of options in terms of accessing somatically oriented therapies, there's a good starting point. There's a website called Pain Psychotherapy Canada that they do have some practitioners who provide virtual care to Saskatchewan, but they may also be able to connect folks with people more local who could help out with some of this. So that's a very, very fast lightning round discussion of this, but I'm absolutely happy to answer questions or take comments